Okay, so good morning and welcome to day one of course one of the mini-residency. As you know, we're running this over a 3-year duration here in London, and during that 3 years we are going to be covering the didactic part of orthodontic diagnosis, treatment plan, appliance design, treatment of cases. We'll also be looking at a series of your cases from beginning to end, so that we can sort of apply the theoretical aspects of the course to the clinical aspect of your own practice. As I said earlier, I'm not about, in this course, trying to sell you an appliance. You know, there's no Mahony expander, there's no Mahony bracket, there's nothing that I want you to specifically buy. I'm going to give you recommendations of what I use in practice, and the reason I use it in practice is because I believe it gives me a good clinical outcome. Yeah? For every product I recommend, there's always going to be 2 to 3 competitor products which are just as good. And again, that's something that you're going to have to source and find out. What I'm more interested in is your ability to look at a case and to evaluate it so that you can break it up into a treatment plan, and so that you don't miss certain factors such as a vertical growth tendency, such as an obstructive airway, such as an anterior tongue thrust. Something that I know is contributing to the cause of the malocclusion, but if it's not picked up early, is going to affect the stability or the end result. My background, just briefly, in orthodontics, I graduated University of Sydney, and back then the education in orthodontics as an undergraduate was very, very poor. In fact, in the entire 5-year program, we had 2 orthodontic lectures of 1 hour duration. That was our orthodontic module. And one of the lectures was basically angles classification, which I think is so archaic. And the second lecture was how to refer to an orthodontist. And that was pretty much all the powers of darkness really wanted us to learn. After graduating, obviously my thirst for knowledge was more in orthodontics than anything else, because when you graduate, probably one of the first patients you see is a 9-year-old with blocked out laterals, and the mum says, "What do we do?" Yeah? And this is what really sort of started my passion for orthodontics. But the way I practice orthodontics now is totally different to the way that I was taught orthodontics as a postgrad student here in your country at the Eastman. That's not to say there was anything derogatory about the course. Back then it was certainly one of the leading courses. It was one of the first courses to be teaching straight wire. But much of the diagnosis was based on dental crowding, and therefore a lot of the treatment plans were quite heavy-handed in the extraction of teeth. And one thing that I will teach you over the next 3 years is when to extract, when to treat non-extraction. And my paradigm shift, my decision on extraction or non-extraction used to be based on millimeters of crowding. Now, whether I extract or not is based on the facial profile. So in a full face, in a face that is a vertical component with lip incompetency, I would extract teeth so that I can retract the incisor, so I can close the bite. And the irony is that those are cases that tend not to have too much crowding. Whereas cases that I would normally extract teeth with, say, 10 millimeters of crowding, if they are mid-face deficient, if they are vertically overclosed, deep bite, if the face doesn't lend itself to retraction orthodontics, then they're the cases I actually now treat non-extraction. Why are we able to now treat non-extraction? Due to improvement in the appliances available. Passive self-ligation has made a huge difference. Due to the fact that we treat children in that category much earlier than we used to, using orthopedic appliances, etc., etc. So the whole method of diagnosis, the whole method of treatment in orthodontics has changed drastically in my sort of 20 years of clinical practice. So I like the analogy of a chess match. I enjoy chess. I think it's a very intellectual challenge, and it's very similar to what we do in orthodontics. Why? Because you have 32 pieces, just like you have 32 pieces of ivory that you're dealing with. And in chess, when you make a move, you know there's certain things you can and can't do. So for instance, your knight can move in a certain direction, your horse can move in another direction. You know that if you move this here, there could be an adverse response in you've opened up your queen and you've lost the match. So in a similar way, what I want to stress is that if you do the wrong diagnosis in orthodontics, you're already digging yourself a grave. And that's why it's important to spend a lot of time with diagnosis. Now, most of you, if not all of you, would have been exposed to Engel's philosophy. Engel is really the father of orthodontics, and many of his patents are still used today. The edgewise slot, yeah, is his invention. And Engel was really a man ahead of his time in that he believed that everyone should have an ideal occlusion without the extraction of teeth. The problem was he was using very heavy forces and he was using them at the wrong time. Like he was treating adults with what's called E-arches. So as a result, even though he got the teeth straight, they didn't stay like that. And his two biggest disciples, Dr. Tweed from the States and Dr. Raymond Begg from Australia, looked at his cases and said, well, whatever he's doing is not stable, therefore, to try and improve stability, we're going to start new techniques. And unfortunately, those techniques that they were promoting were heavily extraction-based. So the pendulum went from non-extraction to a period of time where extraction rate was 90% of cases. That pendulum, I'm glad to say, is slowly swinging back, right? And we have this man to thank. He also introduced the very first classification system. And this is where the confusion arises. To this day, in an orthodontic school, you will hear a lecturer saying this patient has a Class 2 Division 1 malocclusion. What does that mean? That normally means the child has an increased overjet. Does that make sense? However, it simplifies the classification so that it would make you think that there's only 4 possibilities of malocclusion. What I want to share with you is the classification system that I've been using for the last 15 years, which not only helps me to classify the malocclusion, but also gives me the appropriate treatment plan. Yeah? And rather than having 4 options, we have 54. So I'm going to start by reviewing that. I don't expect you by the end of today to be able to look at a series of records and come up with a 54, but I do expect that by course 3. Your assignment, if you choose to do it, is I send you a patient's records, which are ideal standard, so you know what ideal standard means, and your job is to tell me which of the 54 malocclusions this patient represents. That's part 1 of the question. Part 2 of the question is for you to break up that patient's treatment into myofunctional problems, skeletal problems, dental problems. Yep? So the assignment always links with the teaching. And I always say to doctors, if you can't classify the malocclusion, you really shouldn't be doing the treatment. So it's not as though you have one technique and you're going to throw it for every malocclusion. You could have 54 different options. And those options are based on skeletal, dental, vertical, and amount of facial growth remaining. So let me introduce you to this X-ray, Many of you would know it as a CEPH, lateral cephalometric radiograph. I think in your country you actually use the word KEF. Is that right? The type of X-ray I need is a modified lateral KEF. This is called a lateral spine view. What does that mean? It means that your normal X-ray, which is a 5x7 film, shows me the entire cranium. I'm not a neurosurgeon and I'm not really interested. So I'm more interested in the cervical vertebrae. So there is your objective. When I send you the ideal records, you have something to show your radiologist, the person taking your X-rays in your practice. That's what I expect. Why? Because I gain a lot of information from this in regard to the patient's posture, which could lead on to cranial problems, airway-related issues, in regard to the amount of growth they have remaining. All I need here is from nasion, because I'm looking at what's called the anterior cranial base, which is from nasion to sella. And that finishes its growth, and we'll talk about growth a lot in this seminar, very early in life. This is a primary synchondrosis. It's purely under genetic control. Growth is complete by age 7. So by age 7, if I take one of these X-rays, I know exactly what type of facial growth that patient is going to have in the future. And I'll be able to guide that facial growth before it's complete. Do I take a lateral ceph before the age of 7? Not really, because the face is still growing and I don't have an accuracy. But 7 is the magic age, on average, for children, where the primary growth center of the face, the synchondrosis, which if you look back to your dental school notes, will explain, completes. But I want that view. From that view, I can look at a number of factors, and really what I'm looking at in the first instance is what is the skeletal breakup. Skeletal is different to dental. So Angle put the two together. So Angle saw a deep overbite, complete to the palate, with upper incisors retroclined. He would automatically say that's class 2 division 2. But we know that you can have a deep overbite, complete to the palate, lateral incisors proclined, maxillary incisors retroclined on a class 3 jaw pattern. You understand? And the treatment of that patient is totally different to a dental division 2, skeletal class 2. Right? So the first thing we want to look at is the skeletal classification. And the way you know it's skeletal, we use the term class. So when I say someone is class 2, class 3, I'm talking about the relationship of their maxilla to their mandible. Nothing to do with their teeth. So you can be edentulous and still be class 2. All right? The difference between what I teach and practice to what Angle was doing, Angle was still very much using study models. Remember, the lateral cephalostat really was only developed in the 40s. You know, Holly Broadbent. Ricketts was the first guy in California to actually even use one. And from then, we were able to start looking at the relationship of the jaws. But the problem is, most orthodontic teaching programs, even at a postgraduate level, only relate maxilla to mandible. For instance, maxillary position is normally denoted by A point, mandibular position by B point. And the A and B difference is normally what people look at for the skeletal classification. And that is fundamentally flawed. Why? Because you can be class 2 between maxilla and mandible here, here, or here. What's more important is the relationship of the maxilla to the cranial base, right? If you've done Bimbler type analysis, which most of you have, that's the factor 1.